It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Preetish Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
82-year-old gentleman with imaging done after a fall. He was asymptomatic otherwise. He was found to have a mass in the region of the pancreatic tail and spleen. And the biopsy is consistent with an Acinar cell carcinoma of the pancreas. And here we're going to discuss potential treatment recommendations for this patient. His ECOG performance status is 0 to 1. And his medical history has a history of prostate cancer, insulin-dependent diabetes, stage 3 chronic renal insufficiency, history of DVT. He's currently on anticoagulation, and he's bilateral knee replacements. His social history is unknown, and his family history is unknown. And basically here is his CT scan of the abdomen. Dr. Siegel, would you like to take the lead on this?
Sure, I'd love to. You can see here we have one slice through a post-contrast MR of the abdomen. And there's a thick-walled, irregular lesion abutting the pancreatic tail. You can also see directly anterior to the spleen is a little bit of intermediate signal intensity fluid. The differential for a mass like that would be actually quite extensive. We know in this particular case it's an Acinar cell tumor, but a adenocarcinoma with a necrotic center could have a similar look. A necrotic neuroendocrine tumor could have a similar look. And even in the right clinical scenario, an involving hematoma or pseudocyst could have a similar look. The Acinar cell tumors in general tend to be well differentiated, round, hypo-enhancing, and usually solid. They can occasionally be cystic. And then the little bit of fluid between the pancreas and the spleen, we really don't know whether that's related to the recent trauma, either to the spleen or to the tumor, or whether the tumor may have breached or ruptured at some point. It's a little indeterminate, but it's an interesting case.
Thank you so much. An endoscopic ultrasound was obtained with an FNA consistent with Acinar cell carcinoma of the pancreas. Stains positive for trypsin. The serum lipase was 348, and the CA19-9 is normal. So what are our current recommendations for treatment? So I would love to get the viewpoint of both Drs. Benson and Dr. Kubi. Dr. Benson, do you have any recommendations in this setting?
Well, I think one point to emphasize here is that we would want to have a multidisciplinary opinion about this case. So this is the type of case we would routinely present at our weekly GI oncology conference, which is multidisciplinary, because what we want to know right up front is this patient resectable? And, or are there any borderline features or areas of concern? And based on what the history, the patient does have a kidney disease, but apparently a good performance status. And so the mainstay of treatment would be surgery. So the first step for me would be to have the surgeon's opinion.
And I do think it's important to emphasize this is a rare type of cancer.
Yes. Certainly adenocarcinomas are the most common. What Dr. Siegel mentioned is a neuroendocrine tumor, but the patient already had a biopsy, so we have the diagnosis.
So Dr. Kuby, what would be your opinion on this case?
So, from the get-go, I will agree. This is probably 1% of all pancreatic cancers, the Acinar type. And it's interesting, you can go 3 or 4 years without seeing a case, and we happen to have 3 in our system right now. So we've had plenty of rich discussion in our multidisciplinary tumor board about these, and a few things have come up. Although they may have an APC gene sort of background, like a colon cancer, there really has never been any meaningful clinical trial to suggest that a specific regimen would be valuable, but we would probably extrapolate to a GI type background for chemotherapy. Obviously, I'll defer to Dr. Benson on that. But from the standpoint of surgery, if the patient is fit enough and the tumor is indeed resectable, then we would probably proceed with resection. In this particular case, Dr. Siegel did a nice job outlining how the tumor appears to extend. It has a weird or unusual cystic appearance, and it does extend into the spleen. So Dr. Benson brought up the point about borderline or locally advanced. In this case, because it's so far towards the tail of the pancreas, it's not going to involve the celiac axis or the SMA and the traditional discussion of borderline. So technically this would be resectable. However, unfairly to Dr. Siegel, she didn't have the ability to scroll through this. And there may be a component that is extending outside of the actual primary tumor, but within the confines of the location. So our discussion would be to start with a diagnostic laparoscopy and confirm that it appears localized and resectable before proceeding.
I guess the question would be here for this gentleman that's elderly and frail. What if he's not a candidate for surgical resection? What's the best way to approach this patient then?
What I think we would consider for localized disease, whether or not perhaps chemoradiation would be an appropriate strategy. Otherwise, with combination chemotherapy, which we typically use for the more common pancreatic adenocarcinoma, these regimens aren't necessarily easy on people. Now, it was mentioned that this patient had a good performance status. So perhaps either approach, combination chemotherapy or chemoradiation for locally advanced disease. One of the perhaps advantages of radiation, and we should receive the opinion from a radiation expert, but that the treatment could be fairly limited because sometimes we give chemoradiation, after which we observe and monitor the patient. And even though, of course, there's potential risk of toxicity with chemoradiation, it's a fairly abbreviated approach and one I think worth consideration. As mentioned, this is a very rare disease, so we don't have clinical trial data to guide us, so we extrapolate. And if we extrapolate, for example, looking at an adenocarcinoma of the pancreas, these are the type of approaches I think we take.
I would love to hear Dr. Patel's opinion, given that this, although his performance status is excellent, we are talking about an elderly gentleman with multiple comorbidities and possibly not a surgical candidate, depending upon the diagnostic laparoscopy. So,
yeah, no, thank you. I agree with what's been discussed already. I think chemoradiation is maybe something reserved for this type of a case where upfront surgery or multi-agent systemic therapy is not the optimal choice to begin with. For I think as has been stated, we would be extrapolating here as well in terms of the principles that we would use to decide about radiation modalities in a situation like this. And really any of the pancreatic cancer cases that we'll discuss, I think we now think about either chemoradiation or SBRT, stereotactic body radiation therapy, as both being options for treatment. Often it's really the distance from the tumor to the luminal GI organs that helps us make that determination. Dr. Siegel did a great job, but we'd want to evaluate the full sort of extent of the tumor. And really, in my case, I'm looking at how close is it to the jejunum, how close is it to the duodenum and the stomach. And these are the types of anatomic considerations, I think, that go into determining whether we talk about an SBRT approach or a chemoradiation approach. We'd extrapolate from adenocarcinoma of the pancreas in terms of dosing. We do treat Acinar carcinomas in other parts of the body, so radiation is often used for Acinar carcinoma of the parotid, for example. I would extrapolate that as sort of a standard radiation dose is what we would use. So 33 Gray and 5 fractions would be an SBRT regimen that's widely accepted here, or something between 50 and 60 Gray with concurrent 5FU would be a chemoradiation strategy.
Thank you so much. Great discussion regarding a very rare tumor.